Good morning, and I'm Stephan. I'm from the VA. Thanks for having me. I'm gonna. That works. Perfect. So I'm going to talk a bit about, most of what I'm going to talk about actually are the themes that have already been mentioned, and perhaps talk about how over the years we've tried to actually implement some of these in a large health system. I think many people here are quite familiar with the VA as a medical care organization, but perhaps not thinking about it in terms as a population health organization. So we have it's a big health system with over 9 million enrollees and 1,200 sites of care, and lots of visits, lots of surgeries, and lots of inpatient admissions. But I think often people don't also think about the social missions of the VA. Bill and others talked about housing. We do housing first. We issue HUD-VASH waivers, Section 8 waivers to patients, and we screen everybody who comes in for primary care visits for homelessness. Education was on Bill's list. Everyone knows about VA educational loans and housing loans through VHA. We provide occupational training. We operate vet centers in the community where that provides a social network for veterans, particularly those sort of on the fringes of society. We are very heavily invested in suicide prevention, and we give pensions to people, income subsidies, and we know that income is very important as well as housing. So I practiced in the VA my whole life, and it's great to work in a system where actually many of these barriers to providing care, you can, and Bill's exactly right. When I've got a difficult patient, the first thing we try to do is to get them a home. Here, let me see if I'm going to do this. There that go. So just a few examples of ways in which we've started to look at this. We have, for the last 8 or 9 years, used a predictive risk function to identify patients at risk for death or hospitalization, and it's quite accurate. You can see by the C statistics there, and we provided it to primary care providers on a weekly basis, updated for their panels of patients, as I said, I think since 2010. If you look at what's in that current score now, Sarah's quite right. The major determinants really are medical, that is for death, and for utilization. There are other utilization variables, but also important have been sociodemographic factors. So you can see not only do we use age and marital status and the usual, but we do put in the SES index that people have already discussed. And one of the things that I found quite interesting is branch of service and rank. So there's a very different demographic, say, that goes into the Navy or the Air Force than goes into being if you will, a grunt in the Army. And what their rank was. There's a big difference between enlisted men and officers. And those carry through for their entire lives, actually, which is fascinating. So we've incorporated those into our metrics, although Sarah said that they're not the major ones, but they are statistically important as we get up to the higher predictive levels. We've been working with Hadi and our colleagues, Jonathan, and our colleagues at Hopkins, really to try and get down to neighborhood levels and sort of understanding some of the risk factors. This is a map of obesity that they have developed. We've got lat-long coordinates for every patient in our database, so we can locate them down to the census tract and then correlate that with key variables. And this just shows the progression, the VA progression of obesity over the last couple of decades. And what you can see actually is it looks quite different from the CDC one, doesn't it? With a cluster, this is for men, which is why I showed you, clustered up in the northern Midwest, not in the Southeast where we're used to seeing it, which is a bit of a puzzle. Some of that actually is driven by actually Native American reservations, as we've seen. And so, getting a better understanding of some of our health challenges, almost 75% are overweight or obese in our population. So understanding them from a slightly different non-medical perspective, and then even drilling down within some of the metropolitan areas to specific census tracts where we, correlate with other sociodemographic variables to better understand some of these risks and, hopefully get to the point where we can tailor interventions and services into those geographic areas. We've also worked with our colleagues at Hopkins to start doing inventories of sociodemographic variables that we can actually pull into our corporate data warehouse. Some of these are being acquired, some are at this point aspirational. And this looks like the list that everybody else has shown so far and agreed that it's a non-standardized list. But really getting down to the level where we can acquire these variables and integrate them into our, with our other data. And we've actually taken some limited steps in trying then to, as we were just told, get to the analysis phase of how that works. So this is work that my colleague Kari Nelson did several years ago, I think published, so this was done 8 or 9 years ago, acquiring some of the sociodemographic data that had been amassed at RAND with Jose Escarce, and just looking again at the effect on mortality based on neighborhood socioeconomic data. And as you can see, it includes things like neighborhood characteristics and so forth. And sort of quantifying what that looks like. More recently, what we've looked at is, this gets back to what I think was also said about, looking at these neighborhoods. If you look at the SES index, it shows a remarkable relationship to mortality, but we also have income data. And if you then adjust for income data, that is attenuated, to a large extent by knowing what folks' income, their actual income is from our records, as opposed to using the neighborhood variable. So that's just an example where we try to get a large body of sociodemographic information integrated with our EHR data and try better to understand our population. And I realize these are nascent efforts, but again, things we've been trying to do over the last few years. So thanks very much.
So we are on time.